This lecture is about diabetes and pregnancy. I'm going to break it down into 3 screencasts, and in this one I'll talk about the normal metabolic changes of pregnancy. Diabetes in pregnancy is becoming more of a prevalent problem in obstetrics as our average women of childbearing age is becoming older and having more comorbidities like obesity and hypertension. Obese women are 8.5 times more likely to develop diabetes in pregnancy than women of a normal BMI. And 20% of individuals over the age of 20 in the U.S. have undiagnosed diabetes, so it's a problem. So this is just a description of what diabetes is, and you know this from Nursing 106. Diabetes mellitus is a complex disorder, and it results in an accumulation of unmetabolized glucose in the blood. And this is the same problem when a pregnant woman is diabetic, or if a pregnant woman becomes diabetic during the pregnancy, and it has severe potential complications to the pregnancy. So to look at the effects of diabetes in pregnancy, you first need to look at the normal characteristics of pregnancy as they're related to the endocrine system. Pregnancy itself has a diabetes-like effect that puts stress on the mother's physiology, and this is called the diabetogenic effect of pregnancy. So these are normal changes. So during pregnancy, as you already know, there are many maternal changes that occur to help support the pregnancy. And the maternal metabolism also changes and is directed towards supplying adequate nutrients to the fetus. It changes the way we respond to glucose and insulin, and several other changes. So let's look first at early pregnancy. Early on in pregnancy, it's important that the growing embryo and the growing fetus get sufficient glucose to be able to grow and develop. So glucose is mainly diverted across the placenta to the growing embryo and fetus. At the same time, amino acids and lipids are being diverted to the fetus as well, and because of this, the woman has a poorer ability to synthesize glucose. This results in an increased glucose storage, which is good for the fetus, but it also causes a mild fasting hypoglycemia for mom. The normal blood sugar range is considered 70 to 110, and in pregnancy, in a normal pregnancy, it usually hovers around the 70 range, especially early in pregnancy. There's also some insulin resistance that's starting up early in pregnancy related to the increasing amounts of estrogen and progesterone that are being produced. And again, it's just trying to build up glucose stores for the developing fetus. Then as pregnancy progresses and the placenta grows, there is an increased secretion of human placental lactogen, or HPL, and this is an insulin antagonist hormone, so that insulin resistance that started earlier in pregnancy increases. And actually, by the 3rd trimester, the amount of insulin that the woman's pancreas is secreting doubles because of this insulin antagonist hormone. She needs to produce more. Now, this is in a normal pregnancy. For the woman, insulin needs decrease in early pregnancy because she is mildly hypoglycemic, and then they increase in later pregnancy because of the increasing human placental lactogen and the increased insulin resistance. So you can see if a woman goes into pregnancy who is already diabetic, this is going to change how her diabetes is managed, the amount of insulin she needs, that kind of thing. And it can also be a problem for for a woman that becomes diabetic during the pregnancy. Sorry, this is what I just said about her insulin needs decrease in early pregnancy and then increase in later pregnancy. This is normal. So these are just some definitions. Pregestational diabetes refers to diabetes mellitus that was diagnosed prior to becoming pregnant, and this could be type 1 diabetes or type 2. Gestational diabetes is a diabetes that has its first onset during the pregnancy, or at least it's first detected during the pregnancy. Any previous metabolic pathology or predisposition is going to be augmented by these normal metabolic changes and put stress on a woman, and it may be enough for her to develop gestational diabetes. Gestational diabetes represents 90% of all diabetes in pregnancy, so that's what we're going to be focusing on in this screencast, in this class. So let's talk about the effects of diabetes on pregnancy. Really, we're talking about the effects of the accumulation of unmetabolized glucose in mom's blood, just like we worry about in diabetes mellitus in non-pregnant women. So there is an increased risk of complications, particularly perinatal mortality, but the risks do decrease with good glucose control and close fetal monitoring. So we'll talk about that. Some of the risks to the mother include an increased risk of preeclampsia, which we have not discussed yet, but we will. It's a hypertensive disorder of pregnancy, and it's very dangerous, and they have this increased risk because of the endothelial damage that occurs from the hyperglycemia. There's an increased risk of thromboembolism, and this is even beyond the normal increased risk during pregnancy, and that's also related to the endothelial damage from the hyperglycemia. There is an increased risk of infection because of mom's hyperglycemia, so greater incidence of UTIs, vaginal yeast infections, and group B strep, and they can cause problems, which you will have learned about when we talked about infections in pregnancy. And also these are red flags. If we see a pregnant woman, a non-diabetic pregnant woman, or non-diagnosed diabetic woman who is having excessive infections of this type, then that's a red flag to test further for diabetes. Some other maternal risks related to the diabetes. Hydramnios, and that may be a new term for you. It simply means excessive amniotic fluid. It's defined as greater than 2,000 milliliters at term, but we can recognize hydramnios at any point in the pregnancy. We know how much amniotic fluid we expect to see. So the reason for the excessive amniotic fluid is you have to know where does the amniotic fluid come from, and it's mostly comes from fetal urine. So the fetus has an increased urinary output, and this is because he's hyperglycemic. The extra glucose that mom has in her bloodstream does cross over the placenta to the fetus, so he is going to act like anyone else that's hyperglycemic, and he's going to have a greater urinary output. So what's the problem with hydramnios is that it creates a uterine stretch. It overfills the uterus, and that can lead to a premature rupture of membranes or preterm labor. There's also a greater risk of difficult labor, and that another name for that is dystocia, and possibly a cesarean birth related to the large size of the fetus, and we'll talk about why that is. But a large fetus or a large newborn is called macrosomic, just means large. She also has a greater risk of postpartum hemorrhage, also related to the uterine stretch. As we talked about, anytime the uterus is overstretched, it's going to have a more difficult time contracting after delivery, and so a greater possibility of uterine, of postpartum hemorrhage, from an atonic uterus. Okay, effects on the fetus. Well, as I said, he is going to have hyperglycemia also because of the glucose that's passing over through the placenta. And a higher than normal blood glucose in the first trimester is teratogenic, so it causes fetal damage. It causes embryonic or fetal damage, and particularly central nervous system and cardiac and skeletal, particularly cardiac, can cause anomalies. So it's dangerous. And a lot of times early in pregnancy, the woman may not even realize that she is diabetic and that her blood glucose level is high. So that can be a concern. That's one of the reasons we encourage pre-pregnancy planning, so that we can look at risk factors and make sure that she's not at risk for diabetes. Okay, so other risks to the fetus, SAB or spontaneous abortion, and that's also related to the teratogenic effect of hyperglycemia, and a greater risk of fetal demise. And remember, spontaneous abortion is loss of an embryo or fetus prior to 20 weeks gestation, and if the fetus dies after 20 weeks but before birth, we call it a fetal demise. So greater risk for fetal demise related to ketoacidosis or uteroplacental insufficiency, and that means the placenta is not being perfused well. I'll show you a picture in a minute of a uterus with calcification, calcifications on it, which can happen with diabetes because circulation is affected. And so if there's not good perfusion in mom, there's not going to be good perfusion through the placenta, and that can cause fetal demise. Other fetal risks. Well, I talked about a macrosomic infant from mom's point of view, and the fact that having a large baby can make labor difficult. She has a greater risk of perineal trauma, a greater risk of requiring a cesarean section. So for the infant, he can come out either LGA, which stands for large for gestational age, which means he's bigger than what we would expect at his age, or he's macrosomic, same thing. And that's from the increased utilization of glucose that comes over from mom. Or he could be IUGR, which is intrauterine growth restriction, or a smaller baby than what we're expecting for the age. And that's because of poor placental perfusion. So it really depends on the extent of the vascular damage in the placenta. He could either come out extra large, or if there's more vascular damage so that he's not getting the circulation, he can come out IUGR. And I've got a picture here in a minute. And like I said, mom's at risk for preterm labor and he's at risk for preterm birth. It's kind of the same thing related to that uterine stretch. And also because of the hydramnios. If her uterus is stretched because of extra fluid, she could go into early labor. And then birth trauma. So mom's perineum could be injured from a big baby, and the baby himself could be injured. He could have broken bones, he could have nerve damage from a difficult delivery because of his size. So here are a couple of pictures that show a wide variation in neonates that you can see with infants of diabetic moms. So these babies could be the same gestational age. They could both be 39 weeks gestation. And the one on the left you can see is macrosomic, and the one on the right is IUGR. So same age, different size. Neonatal risks. I'm going to discuss neonatal risks in more detail in our last class, which is newborn complications. But for right now, there are some things that I want you to know about risks to the newborn. Hypoglycemia is a big one, very dangerous. I'm going to talk about that in a minute. Polycythemia. So they're born with excess red blood cells, and that's to compensate for poor placental perfusion. One of the ways that they adapt to having poor perfusion from mom is they produce more red blood cells. So that's one of the reasons they come out ruddy looking. You can see in this picture, both of the babies look kind of red. Their color looks good. They look like they're healthy babies, and they both may be really sick. So that's the polycythemia. They're also at risk for hyperbilirubinemia, also very dangerous for a newborn, and that's just from the breakdown of the excessive red blood cells. They're at risk for respiratory distress syndrome. We will talk about that more in the last class. RDS it's called, and that's a problem where there's too little surfactant in the infant's lungs. That's the substance that lines the alveoli and allows them to open up. If there are high levels of insulin present, that inhibits the production of surfactant. So you don't really need to know what surfactant is. You don't really need to know what RDS is at this point. What I want you to know is that a newborn of a woman that has diabetes is set up for all these problems. Even if the delivery's okay and he makes it through his gestational period okay, that doesn't mean he's out of the woods. There's also a significantly increased risk of childhood obesity in infants of diabetic moms. So I mentioned neonatal hypoglycemia, and again, I'll go into that in much more detail, but it's very dangerous for a newborn. So what's happening is mom is hyperglycemic, and the glucose does cross the placenta, but insulin doesn't. So the fetus has to produce his own insulin. He's not diabetic. His mom's diabetic. So his pancreas is working fine, and in response to the extra glucose, he's going to produce more insulin. Mom's hyperglycemic, leads to fetal hyperglycemia, and he kicks up the fetal insulin production. Then what happens? The umbilical cord gets cut at delivery, mom's glucose supply gets cut off, and meanwhile, he's still producing the high levels of insulin. So now he's dependent on whatever glucose stores he has, or that he's getting from eating, and that gets broken down by the insulin, or metabolized by the insulin very quickly, and he becomes hypoglycemic. And that's a big problem that we watch for.